Thank you very much, Renzo. Hello, everybody. It's 8 o'clock. We had a wonderful evening yesterday, and it's my pleasure to catch up on radiotherapy advances that we now face. As radiotherapy advances affect very much the patients that are diagnosed with screening detected cancers. So current standards for stereotactic body radiation therapy that we use in Gdańsk were introduced by the colleagues from the Netherlands. Basically, Professor Mazzarotti will speak about it. We use 54 grays in 3 fractions for peripheral tumors, 50 to 55 grays in 5 fractions with the tumors close to the chest wall, and 60 grays in 8 fraction schedule, which is used in Europe mostly for the tumors that are located 1 to 2 centimeters from mediastinum. Still, for those tumors that are called ultracentral tumors, located less than 10 millimeters from mediastinum, we use 60 grays in 20 fractions, which is hypofractionated, more classical radiation therapy, due to still some doubts about the safety of this technology. The current technologies are IMRT or VMEDs with breath holding, or for the CT planning technology, depending if the patients can hold the breath accordingly. All right, this is an example of 54 grays in 3 fraction regimen. This is what we do with tumors abutting the chest wall, 55 grays in 5 fractions. This is when the tumor is located close to the heart, close to the mediastinum. We use the regimen that's based on European data of 60 grays in 8 fractions. Our American colleagues would tend to use 50 grays in 5 fractions in this setting. And that is the outcome, the slide that covers outcomes of local relapse-free survival, regional relapse-free survival, and metastasis-free survival, and overall survival, which is much inferior to local control. This slide is already 10 years old. It presents one of the largest series of SBRT-treated patients from Amsterdam. And I can tell you only from our data sets from Gdańsk that we have very same overall survival data and local control data. Why is that? Actually, competing risks for these patients who are non-surgical candidates makes the overall survival much worse than local regional control. And the median overall survival in this series, and remarkably also in our Gdańsk series, is exactly 3.5 months. So keep in mind that most of the series that we see today are covering patients who have many comorbidities like COPD, other pulmonary deficits, cardiovascular, diabetes, and so on. So how do we expand on SBRT right now? First of all, ultracentral tumors, the tumors that are located close to mediastinum, within 10 millimeters from mediastinal structures. This is somewhat newer definition of SBRT, as traditional is 20 millimeters. This is our LungTech Sabre ultracentral protocol that we initiated with the ERTC lung group. The trial actually used in CDCO planning first with very carefully designed organs at risk doses that should be used in this trial to document the safety of this approach. Actually, the trial was stopped prematurely because of 2 deaths that could have been attributed to SBRT. However, we are truly not sure whether these 2 deaths were really due to radiation. And the long-term outcomes from this study were quite favorable. Nevertheless, 60 grays in 8 fractions remains investigational for very ultracentral tumors, and I don't use this approach. Our US colleagues, our United States colleagues, and in North America, ultracentral tumors are treated according to RTOG 0813 trial, which was a dose-finding study that ended up with 50 grays in 5 fractions as being safe and also good tolerance of 55 to 60 grays in 5 fractions. Now, operable stage 1 non-small cell lung cancer, there were 3 randomized trials, Roselle, STARS, and RTOG study, all closed early due to poor accrual, and unfortunately did not allow us to make firm conclusions. We have the publication from pooled analysis of 2 of these studies showing us that stereotactic radiation therapy was certainly not worse than surgical treatment in these randomly allocated patients. Blue curve is for SBRT here. And then we also have other data which are mostly retrospective and propensity score matched. As for example, this series from the Free University of Amsterdam, again in operable patients, this time with excellent local control, regional control, and very good here overall survival in this patient group. Now, maybe 20 propensity score matched analyses are available in the literature, telling us sometimes that SBRT is slightly better, sometimes that surgery is slightly better. So with no randomized data, we cannot really tell. Something that's also very relevant is that SBRT is used in these series rather in older patients. And we know that in older patients, the outcomes may be less favorable, as simple as that. Now, there are 2 important prospective trials now that I could see in the clinicaltrials.gov database. One is American observational study. It's comparing the effectiveness of surgery versus stereotactic body radiotherapy for stage 1 non-small cell lung cancer. It's not randomized. And the other one is of particular interest. It's again a US-based study, the Stable Mates, in which there is a random allocation to SBRT versus surgery in well-defined high-risk patients for surgery. And this study should tell us more, hopefully, when it's finalized, whether these true modalities are truly equivalent. Now, clinical trials that are combining SBRT and systemic treatments, one of the most important that is to close accrual this year is a long ongoing RTOG 3515 study, or Pacific 4, in which patients treated with SBRT with high-risk disease, defined as mostly T2, T3 tumors, are randomized to consolidation durva for 24 months versus placebo, with the primary endpoint of progression-free survival. Another important study that was a phase 2 study presented by Dr. Altorki and colleagues was a randomized phase 2 study with neoadjuvant immunotherapy, just 2 cycles of durvalumab, plus minus SBRT, 3 times 8 grays, so the dose that we would not use with SBRT alone because of the suboptimal dose, biologically effective dose, and then followed by surgery. Interestingly, a very high rates of pathological responses, much higher in SBRT group. So in summary, SBRT is important local treatment in early stage non-small cell lung cancer. We'll definitely see increasing use of this modality in screening detected cancers as well. And we have seen a very nice study yesterday that is now in publication in press from the Claudia and David's group on screening detected cancers. The proper staging is still essential. PET-CT and EBUS, very important. Excellent safety if technical principles are applied. Excellent local control and current clinical trials looking at ultracentral tumors, patients with high risk of surgical complications, and SBRT combined with surgery in very selected high-risk patients, and I just touched base on this. We have more clinical studies now being designed. With that, I'll stop, and I'll ask my colleague, Professor Renzo Mazzarotti, to speak about technical components of SBRT. Thank you.